Hello dear friends, welcome to PharmaGrid. So in our last video, we have discussed about antiplatelet agents. So today we are going to learn about anticoagulants and thrombolytic drugs. So let's first learn about blood coagulation. The coagulation cascade or secondary hemostasis is a series of steps in response to bleeding caused by tissue injury where each step activates the next and ultimately produces a blood clot. Okay, so therefore the term hemostasis means to stop bleeding. There are mainly two phases of hemostasis. First one is primary hemostasis, which means formation of an unstable platelet plug at the site of injury. Okay, so this we have seen that the platelet response to vascular injury. We have seen this in our previous class regarding the antiplatelet agents. And after that, the coagulation cascade is activated to stabilize the plug, stopping blood flow and allowing increased time to make necessary repairs. This process minimizes the blood loss after injuries. The coagulation consists of mainly three pathways: the extrinsic, intrinsic and the common pathways that interact together to form a stable blood clot. The extrinsic and the intrinsic coagulation pathways both led into the final common pathway by independently activating factor 10. Okay, so the coagulation process that generates thrombin consists of two interrelated pathways, that is the extrinsic and the intrinsic system. The extrinsic system is initiated by the activation of clotting factor 7 by tissue factor. Tissue factor is also known as thromboplastin. This tissue factor is a membrane protein that is normally separated from the blood by the endothelial cells that line the vasculature. However, in response to vascular injury, tissue factor becomes exposed to blood. There, it can bind and activate factor 7, initiating the extrinsic pathway. Okay, so this is how this extrinsic pathway is initiated. Now coming to the intrinsic system, it is triggered by the activation of the clotting factor 12. This occurs when blood comes into contact with the collagen in the damaged wall of a blood vessel. Thrombin plays a key role in coagulation because it is responsible for generation of fibrin. Fibrin forms the mesh-like matrix of the blood clot. Before going deep into the coagulation cascade, it is very important to know about the different clotting factors. The coagulation cascade involves the activation of a series of clotting factors, which are proteins that are involved in blood clotting. Each clotting factor is a serine protease, an enzyme that speeds up the breakdown of another protein. The clotting factors are initially in an inactive form called as zymogens. When placed with its glycoprotein cofactor, the clotting factor is activated and is then able to catalyze the next reaction. When a clotting factor becomes activated, it is denoted with an alphabet, that is a small letter A, following its respective Roman numeral. For example, when factor 5 becomes activated, we will write it as factor 5A. Okay, that means small letter A. Okay, so the different clotting factors include factor 1 is known as fibrinogen and the factor 2 is known as prothrombin. Factor 3 is known as tissue factor or thromboplastin. Factor 4 is calcium and factor 5 is proaxlerin or labile factor. Then factor 6, it is unassigned. Okay, there is no factor 6 or it is unassigned. Then factor 7 is known as stable factor or proconvertin. Factor 8 is known as antihemophilic factor A. Factor 9 is known as antihemophilic factor B or Christmas factor. Factor 10 is Stewart-Prower factor. Factor 11 is plasma thromboplastin antecedent. Factor 12 is known as hegemon factor and factor 13 is known as fibrin stabilizing factor. There are so many mnemonics are available that will help to easily memorize these clotting factors. Okay, so now let's see how a fibrin clot is formed. And here you can see the simplified diagram of this coagulation cascade. As I have already mentioned, coagulation consists of three pathways, that is the extrinsic pathway, the intrinsic pathway and the common pathway. And these three pathways interact together to form a stable blood clot. The extrinsic and intrinsic coagulation pathways both led into the final common pathway by independently activating factor 10. The extrinsic pathway involves initiation by factor 3. Factor 3 is also known as tissue factor and its interaction with a factor 7. Whereas factors 12, 11 and 9 are utilized in the intrinsic pathway. Okay, so these are the factors involved in both the intrinsic pathway as well as the extrinsic pathway. The extrinsic pathway begins when there is an injury to the endothelial tissue thereby exposing the tissue factor to the blood. So how this extrinsic pathway got activated? The extrinsic pathway begins when there is an injury to the endothelial tissue. Endothelial tissue in the sense skin tissue, exposing the tissue factor to the blood. Tissue factor then becomes bound with the calcium and factor 7A to activate factor 10. Factor 7 is present in the blood and requires vitamin K to be activated. Meanwhile, the intrinsic pathway begins when factor 12, factor 12 is also known as the hegemon factor, is exposed to collagen, kallikrein and high molecular weight kininogen and is subsequently activated. Okay, so this is how this intrinsic pathway got activated. It begins when this factor 12, which is also known as a hegemon factor, got exposed to collagen, kallikrein and high molecular weight kininogen and gets subsequently activated. So factor 12A activates factor 11 into 11A. With a calcium ion, factor 11A activates factor 9, then factor 9A, factors 8A and calcium form a complex to activate factor 10. Okay, so factor 8 is found in the blood and is often activated by thrombin. Thrombin means factor 2A. Now coming to the common pathway. The common pathway may result after the activation of factor 10 at the end of either pathway. Okay, so as a result of both these pathways, the intrinsic pathway as well as the extrinsic pathway, the final product formed is the factor 10A. Okay, or the end of either pathway is the activation of factor 10. The common pathway begins when factor 10A, 5A and calcium bind together, forming a prothrombinase complex. The prothrombinase complex then activates prothrombin. Prothrombin is factor 2 into thrombin. Okay, so this factor 10A converts prothrombin to thrombin. Prothrombin is factor 2 and thrombin is the activated form of prothrombin. Okay, so the prothrombinase complex then activates prothrombin into thrombin. Next, the thrombin cleaves fibrinogen into fibrin. This thrombin is responsible for the cleavage of fibrinogen into fibrin. Afterwards, the thrombin cleaves the stabilizing factor. Stabilizing factor is also known as the factor 13 into 13A. And this factor 13A binds with calcium to then create fibrin cross-links to stabilize the clot. Thrombin has several functions including activating the platelets. Platelets are the cell fragments involved in clot formation and activating factors 5, 8 and 9. So now we are familiar about the coagulation cascade. Now we can learn about the anticoagulants. So first of all, the classification. The anticoagulants are broadly classified as parenteral anticoagulants as well as oral anticoagulants. Parenteral anticoagulants are further subdivided into indirect thrombin inhibitors and direct thrombin inhibitors. Indirect thrombin inhibitors include unfractionated heparin, low molecular weight heparin which includes enoxaparin, riviparin, nadroparin, dalteparin, pamaparin and ardiparin, then Fondaparinux and danaparin. Then direct thrombin inhibitors include lepidolin, bivalirudin and ergotroban. Moving on to the oral anticoagulants, the first subcategory is coumarin derivatives, which includes bis-hydroxycoumarin, then warfarin sodium, acinocomerol, which is also known as nicomalon, then ethyl biscumoacetate. Then direct factor 10A inhibitor, which is rivaroxaban, and oral direct thrombin inhibitor, which is known as the dabigatran etixlate. Then in vitro anticoagulants include heparin, sodium edetate, sodium citrate, and sodium oxalate. Okay, so let's start with the parenteral anticoagulants. So the first drug is heparin. Heparin is an injectable, rapidly acting anticoagulant that is often used acutely to interfere with the formation of thrombi. Heparin occurs naturally as a macromolecule complexed with histamine in mast cells, where its physiologic role is unknown. It is extracted for commercial use from porcine intestinal mucosa. Unfractionated heparin is a mixture of straight-chain anionic glycosamine glycans with a wide range of molecular weights. It is strongly acidic because of the presence of sulphate and carboxylic acid groups. The low molecular weight heparins are heterogeneous compounds about 1/3 the size of unfractionated heparin. So this heparin belongs to parenteral anticoagulants. It is rapidly acting and occurs naturally as a macromolecule complexed with histamine in the mast cells. And it is extracted for commercial purposes. It is extracted from the porcine intestinal mucosa. And this unfractionated heparin is a mixture of straight-chain anionic glycosamine glycans with a wide range of molecular weights. This heparin is strongly acidic due to the presence of sulphate and carboxylic acid groups. Low molecular weight heparin, for example enoxaparin, dalteparin, they are produced by the depolymerization of unfractionated heparin. And these low molecular weight heparins are heterogeneous compounds about one-third the size of unfractionated heparin. Moving on to the mechanism of action of this heparin and low molecular weight heparin. Heparin accelerates inactivation of coagulation factors by antithrombin 3. So what do you mean by this antithrombin 3? Antithrombin 3 is an alpha globulin that inhibits serine proteases of thrombin and factor 10A. Thrombin is also known as factor 2A. In the absence of heparin, antithrombin 3 interacts very slowly with the thrombin and factor 10A. So when heparin molecules bind to antithrombin 3, a conformational change occurs that catalyzes the inhibition of thrombin about 1000-fold. Low molecular weight heparins complex with antithrombin 3 and inactivate factor 10A, including that located on platelet surfaces but do not bind as avidly to thrombin. A unique pentasaccharide sequence contained in heparin and low molecular weight heparins permits their binding to antithrombin 3. Okay, so let's see this diagram so that the mechanism of action will be more easier. So as I have already said, this antithrombin 3 is an alpha globulin that inhibits the serine proteases of thrombin, which is factor 2A and factor 10A. So in the absence of this heparin, the interaction between this antithrombin 3 and thrombin and factor 10A is very slow. So let's take the case of this unfractionated heparin. This unfractionated heparin accelerates the interaction of antithrombin with both the thrombin and factor 10A. Now this is the case with low molecular weight heparin. Low molecular weight heparin selectively accelerates. Selectively accelerates means selectively fasten the interaction of this antithrombin with a factor 10A. Okay, so this is the difference in mechanism between this unfractionated heparin and a low molecular weight heparin. This unfractionated heparin accelerates the interaction of antithrombin with both the thrombin and a factor 10A, whereas this low molecular weight heparin selectively accelerates the interaction of antithrombin with a factor 10A. A unique pentasaccharide sequence contained in heparin and low molecular weight heparin permits the binding of antithrombin 3. Therapeutic uses. Heparin and the low molecular weight heparins limit the expansion of thrombi by preventing fibrin formation. So they are mainly used for the treatment of acute venous thromboembolism, which is deep vein thrombosis or pulmonary embolism. Then for the prophylaxis of post-operative venous thrombosis in patients undergoing surgery, for example hip replacement, and those with acute myocardial infarction. And this heparin and low molecular weight heparins are the anticoagulants of choice for treating pregnant women because they do not cross the placenta due to their large size and negative charge. Low molecular weight heparins do not require the same intense monitoring as heparin, thereby saving laboratory costs and nursing time. These advantages make low molecular weight heparins useful for both inpatient and outpatient therapy. Coming to the pharmacokinetics, heparin must be administered subcutaneously or intravenously because the drug does not readily cross the membranes. Okay, so the route of administration is very important. Heparin must be administered subcutaneously or intravenously. Heparin is often initiated as an intravenous bolus to achieve immediate anticoagulation. This is followed by lower doses or continuous infusion of heparin titrated to the desired level of anticoagulation according to the activated partial thromboplastin time or anti-factor 10A level. Okay, so the monitoring parameter for heparin is APTT, that is activated partial thromboplastin time. Anticoagulant effect with heparin occurs within minutes of IV administration or 1 to 2 hours after subcutaneous injection. In the blood, heparin binds to many proteins that neutralize its activity, causing unpredictable pharmacokinetics. Heparin binding to plasma proteins is variable in patients with thromboembolic diseases. Although generally restricted to the circulation, heparin is taken up by the monocyte or macrophage system and it undergoes depolymerization and desulfation to inactive products. The inactive metabolites as well as some of the parent heparin undergo renal excretion. The half-life of heparin is approximately 1.5 hours. The low molecular weight heparins are usually administered subcutaneously. And one important point is that enoxaparin is a low molecular weight heparin. It can be administered intravenously in the treatment of myocardial infarction. The maximum anti-factor 10A activity of the low molecular weight heparins occurs about 4 hours after subcutaneous injection. It is usually not necessary to monitor coagulation values with low molecular weight heparins because the plasma levels and pharmacokinetics of these drugs are more predictable. Okay, so this is one of the advantage of this low molecular weight heparins over this heparin. Okay, for this low molecular weight heparins, it is not necessary to monitor the coagulation values. Okay, so this is an important advantage of this low molecular weight heparins when compared to heparin. However, in renally impaired, pregnant and obese patients, monitoring of factor 10A levels is recommended with a low molecular weight heparins. In certain special conditions, monitoring of factor 10A level is recommended for this low molecular weight heparins. The low molecular weight heparins are primarily eliminated in the urine. Therefore, renal insufficiency or renal impairment prolongs the half-life of low molecular weight heparins, and the dose of this low molecular weight heparins should be reduced in patients with a renal impairment. The half-life of low molecular weight heparins is longer than that of heparin, ranging from 3 to 12 hours. Coming to the adverse effects, the chief complication of heparin and low molecular weight heparin therapy is bleeding. And the other adverse effects include hypersensitivity, then heparin-induced thrombocytopenia, possible adverse reactions such as chills, fever, urticaria, and anaphylactic shock. On long-term heparin therapy, it can cause osteoporosis. Then, contraindicated in patients who have hypersensitivity to heparin, bleeding disorders, alcoholism, or who have had recent surgery of the brain, eye, or spinal cord. So what do you mean by this heparin-induced thrombocytopenia? It is a serious condition in which circulating blood contains an abnormally low number of platelets. This reaction is immune mediated and carries a risk of venous and arterial embolism. So in cases of this heparin-induced thrombocytopenia, heparin can be replaced by another anticoagulant such as ergotroban. Low molecular weight heparins can have cross sensitivity and are not recommended in patients with heparin-induced thrombocytopenia. So in patients with a heparin-induced thrombocytopenia, the drug of choice is ergotroban. In such conditions, we cannot use low molecular weight heparins because these low molecular weight heparins can have cross sensitivity with the heparin. Antidote for heparin is protamin sulphate. Excessive bleeding may be managed by discontinuing the drug or by treating with protamin sulphate. When infused slowly, the latter combines ionically with heparin to form a stable 1:1 inactive complex. It is important that the dosage of protamin sulphate is carefully titrated. That is, 1 mg of protamin sulphate is required for every 100 units of heparin administered. Because protamin sulphate is a weak anticoagulant and excess amounts may trigger bleeding episodes or worsen the bleeding potential. So point to be noted is that the antidote for heparin is protamin sulphate and the dosage required is 1 mg is required for every 100 units of heparin administered. So the next parenteral anticoagulant is ergotroban. It is a direct thrombin inhibitor. Ergotroban is a synthetic parenteral anticoagulant that is derived from L-arginine. Ergotroban is used for the prophylaxis or treatment of venous thromboembolism in patients with heparin-induced thrombocytopenia. It is also approved for use during percutaneous coronary intervention in patients who have or are at risk for developing heparin-induced thrombocytopenia. So the drug of choice in patients with heparin-induced thrombocytopenia is ergotroban. The anticoagulant effects produced by this ergotroban are immediate, and this drug is metabolized in the liver and has a half-life of about 39 to 51 minutes. Dose reduction is recommended for patients with hepatic impairment, and the monitoring parameters for ergotroban includes APTT, that is activated partial thromboplastin time, hemoglobin and hematocrit. And the major side effect is bleeding. Moving on to the next parenteral anticoagulants, which includes bivalirudin and decitabine. These are parenteral anticoagulants that are analogues of hirudin, which is a thrombin inhibitor derived from the saliva of the medicinal leech. These bivalirudin and decitabine are selective, direct thrombin inhibitors that reversibly inhibit the catalytic site of both free and clot-bound thrombin. So these bivalirudin and decitabine are direct thrombin inhibitors. Bivalirudin is an alternative to heparin in patients undergoing PCI who have or are at risk for developing heparin-induced thrombocytopenia, and also in patients with unstable angina undergoing angioplasty. In patients with normal renal function, the half-life of bivalirudin is 25 minutes. Dosage adjustments are required in patients with a renal impairment. Decitabine is indicated for the prevention of deep vein thrombosis in patients undergoing hip replacement surgery. Like the others, bleeding is a major side effect of these agents. Okay, so the next drug is Fondaparinux. It is a synthetically derived pentasaccharide anticoagulant that selectively inhibits factor 10A. By selectively binding to antithrombin 3, Fondaparinux potentiates in the sense 300 to 1000 fold the innate neutralization of factor 10A by antithrombin 3. Okay, so the mechanism of action of this Fondaparinux is it is a selective inhibitor of factor 10A. This drug is approved for use in the treatment of deep vein thrombosis and pulmonary embolism and for the prophylaxis of venous thromboembolism in the setting of orthopedic and abdominal surgery. The drug is well absorbed from the subcutaneous route with a predictable pharmacokinetic profile and therefore requires less monitoring than heparin. So the route of administration for this Fondaparinux is through the subcutaneous route. Fondaparinux is eliminated in the urine mainly as unchanged drug with an elimination half-life of 17 to 21 hours. It is contraindicated in patients with a severe renal impairment. Bleeding is a major side effect of Fondaparinux. There is no available agent for the reversal of bleeding associated with the Fondaparinux, which means there is no antidote for this Fondaparinux. Heparin-induced thrombocytopenia is less likely with the Fondaparinux than with heparin, but is still a possibility. So we have completed the parenteral anticoagulants, which includes heparin, low molecular weight heparins, argatroban, bivalidin deciridine and fondaparinux. Now we will learn about oral anticoagulants, and the first and foremost one is vitamin K antagonist. The first drug is warfarin. The coumarin anticoagulants owe their action due to their ability to antagonize the cofactor functions of vitamin K. The only therapeutically relevant coumarin anticoagulant is warfarin. The INR means International Normalized Ratio, is the standard by which the anticoagulant activity of warfarin therapy is monitored. So the monitoring parameter for this warfarin is INR. The goal of warfarin therapy is an INR of 2 to 3 for most indications, with an INR of 2.5 to 3.5 targeted for some mechanical valves and other indications. Moving on to the mechanism of action of warfarin, factors 2, 7, 9 and 10 require vitamin K as a cofactor for their synthesis by the liver. These factors, that is these four factors, that is 2, 7, 9 and 10, undergo vitamin K dependent post-translational modification whereby a number of their glutamic acid residues are carboxylated to form gamma carboxyglutamic acid residues. These formed gamma carboxyglutamic acid residues will bind with the calcium ions, which are essential for their interaction between the coagulation factors and platelet membranes. In this carboxylation reactions, the vitamin K dependent carboxylase fixes carbon dioxide to form the new COOH group on the glutamic acid. The reduced vitamin K cofactor is converted to vitamin K epoxide during this reaction. Vitamin K is regenerated from the epoxide by vitamin K epoxide reductase, the enzyme that is inhibited by warfarin. Okay, let's look into this diagram. So these are the four factors. Okay, these here you can see the four factors, that is the polypeptide precursors of clotting factors 2, 7, 9 and 10. What is the peculiarity of these factors? Because these factors require vitamin K as a cofactor for their synthesis by the liver. These factors will undergo vitamin K dependent post-translational modification. Okay, as a result, a number of their glutamic acid residues are carboxylated to form gamma carboxyglutamic acid residues. Okay, so this is the process of this carboxylation reaction. So in this carboxylation reaction, the vitamin K dependent carboxylase fixes carbon dioxide to form the new COOH group on the glutamic acid. Okay, so here you can see the structure of this gamma carboxyglutamic acid residues. So during this carboxylation reaction, the reduced vitamin K cofactor is converted to vitamin K epoxide. Okay, so here you can see during this carboxylation reaction, the vitamin K reduced, that is the vitamin K in the reduced form, get converted to its vitamin K epoxide form. Okay, and this vitamin K is regenerated from the epoxide form by vitamin K epoxide reductase. Okay, so this vitamin K is regenerated with the help of the enzyme vitamin K epoxide reductase, and this enzyme is inhibited by warfarin. Okay, so what this warfarin will do? Warfarin will inhibit the vitamin K epoxide enzyme, which is responsible for the regeneration of vitamin K from the vitamin K epoxide. So as a result, what will happen? This will result in the production of clotting factors with a diminished activity. Diminished activity means 10% to 40% of the normal due to lack of sufficient gamma carboxyglutamic acid side chains. So warfarin treatment results in the production of clotting factors with the diminished activity, that is 10% to 40% of normal due to the lack of sufficient gamma carboxyglutamyl side chains. Unlike heparin, the anticoagulant effects of warfarin are not observed immediately after drug administration. Instead, peak effects may be delayed for 72 to 96 hours, which is a time required to deplete the pool of the circulating clotting factors. Okay, so whenever we administer this heparin, the anticoagulant effect is immediate. Okay, but the difference is that in case of warfarin, the anticoagulant effect of warfarin are not observed immediately. Instead, the peak effects with this warfarin may be delayed for 72 to 96 hours, and this is the time required to deplete the pool of the already circulating clotting factors. The anticoagulant effects of warfarin can be overcome by the administration of vitamin K. However, reversal following administration of vitamin K takes approximately 24 hours. This time means the time necessary for the degradation of already synthesized clotting factors. Therapeutic uses of warfarin include prevention and treatment of deep vein thrombosis and pulmonary embolism, then stroke prevention in the setting of atrial fibrillation and or prosthetic heart valves, protein C and S deficiency, antiphospholipid syndrome, prevention of venous thromboembolism following orthopedic surgery. So what do you mean by this antiphospholipid syndrome? It is an autoimmune disorder that can cause blood clots and miscarriages. So blood thinners work well to treat the syndrome and to help prevent future blood clots and miscarriages. So this warfarin can be used for the treatment of antiphospholipid syndrome. Pharmacokinetic profile of warfarin. Warfarin is rapidly absorbed after oral administration, that is 100% bioavailability with little individual patient variation. It is highly bound to plasma albumin, which prevents its diffusion into the cerebrospinal fluid, urine and breast milk. However, drugs that have a higher affinity for the albumin binding site, for example sulfonamides, can displace the anticoagulant and lead to a transient elevated activity. And this warfarin readily crosses the placental barrier, so it is contraindicated in pregnancy. The mean half-life of warfarin is approximately 40 hours, but this value is highly variable among individuals. Warfarin is metabolized by the cytochrome P450 system, mainly CYP2C9 to inactive components. After conjugation to glucuronic acid, the inactive metabolites are excreted in urine and feces. Warfarin has numerous drug interactions that may potentiate or attenuate its anticoagulant effect. Coming to the adverse effects of warfarin, the principal adverse effect is bleeding. Okay, so this minor bleeding may be treated by withdrawal of the drug or administration of oral vitamin K, but severe bleeding may require greater doses of vitamin K given intravenously. Then this whole blood, frozen plasma and plasma concentrates of blood factors may also be used for rapid reversal of warfarin. Then skin lesions and necrosis are rare complications of warfarin therapy. Then this purple toe syndrome, it is a rare, painful, blue-tinged discoloration of the toe caused by cholesterol emboli from plaques has also been observed with the warfarin therapy. So this purple toe syndrome is associated with the warfarin therapy. Warfarin is teratogenic and is contraindicated in pregnancy. Let's have a look into the drug interactions associated with the warfarin. So when this warfarin is co-administered with the drugs such as acute alcohol intoxication, amiodarone, fluconazole, metronidazole, sulfamethoxazole trimethoprim and tetracycline, this will lead to inhibition of the metabolism of warfarin. Okay, this will ultimately resulting in potentiation of the anticoagulation or acceleration of the anticoagulant activity of warfarin. And also aspirin. We know that aspirin inhibits the platelet aggregation. So when this aspirin co-administered with the warfarin, that will also lead to the potentiation of the anticoagulation. And next case is warfarin when co-administered with the drugs such as chronic alcohol ingestion, barbiturates, dicloxacillin, rifampin, oral contraceptives, that will lead to stimulation of metabolism of warfarin. These drugs are enzyme inducers. So when these drugs are co-administered with the warfarin, that will lead to stimulation of the metabolism of warfarin that will ultimately resulting in attenuation of anticoagulation or decrease in anticoagulant activity of warfarin, and conditions such as pregnancy and nephrotic syndrome can also lead to attenuation of the anticoagulation effect of warfarin. So the next category is direct oral anticoagulants, and the main drug involved is dabigatran. So the mechanism of action of dabigatran is that dabigatran etixylate is the prodrug of the active moiety dabigatran. Okay, so the prodrug is dabigatran etixylate and its active moiety or the active metabolite is dabigatran, which is an oral direct thrombin inhibitor. Okay, so the mechanism of action of this dabigatran is it is an oral direct thrombin inhibitor. Both clot-bound and free thrombin are inhibited by dabigatran. Then its therapeutic uses include prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation. Then for the treatment of deep vein thrombosis and pulmonary embolism in patients who have already received parenteral anticoagulants. And it is also used for the prophylaxis to prevent or reduce the risk of recurrence of DVT and pulmonary embolism. The drug is contraindicated in patients with mechanical prosthetic heart valves and is not recommended in patients with a biprosthetic heart valves. Pharmacokinetics of dabigatran. Dabigatran is administered orally, and we know that this dabigatran etixylate is a prodrug. It is hydrolyzed to the active drug dabigatran by various plasma esterases. Dabigatran is metabolized by esterases. It is a substrate for P-glycoprotein and is eliminated renally. Coming to the adverse effects of dabigatran, the major adverse effect is bleeding. Dabigatran should be used with caution in renal impairment or in patients over the age of 75 years as the risk of bleeding is higher in these age groups. Idarucizumab may be used to reverse bleeding in severe cases. Okay, so an antidote that can be used to reverse bleeding associated with the dabigatran is idarucizumab. Then gastrointestinal adverse effects are common with dabigatran and may include dyspepsia, abdominal pain, esophagitis, and gastrointestinal bleeding. Abrupt discontinuation should be avoided as patients may be at increased risk for thrombotic events. So the next category is direct oral factor 10A inhibitors. So the drugs that comes under this category include apixaban, betrixaban, edoxaban, and rivaroxaban. So the mechanism of action is inhibition of factor 10A and thereby reducing the production of thrombin. Thrombin means factor 2A from prothrombin. Therapeutic uses include, with the exception of betrixaban, these agents are approved for the prevention of stroke in non-valvular atrial fibrillation as well as the treatment of deep vein thrombosis and pulmonary embolism. Rivaroxaban and apixaban are also used as prophylaxis to prevent or reduce the risk of recurrence of DVT and pulmonary embolism. Betrixaban is indicated for the prophylaxis of deep vein thrombosis and pulmonary embolism in at-risk hospitalized medical patients. Pharmacokinetics of this direct oral factor 10A inhibitors. They are adequately absorbed after oral administration. Rivaroxaban is metabolized by the CYP3A4 bar 5 and CYP2J2 isoenzymes to inactive metabolites. About one-third of the drug is excreted unchanged in the urine and the inactive metabolites are excreted in the urine and feces. Apixaban is primarily metabolized by CYP3A4 with CYP enzymes 1A2, 2C8, 2C9, 2C19 and 2J2 all sharing minor metabolic roles. Approximately 27% is excreted renally. Edoxaban and betrixaban are minimally metabolized and are eliminated primarily unchanged in the urine and feces respectively. All of these drugs are substrates of P-glycoprotein and dosages should be reduced. In some cases, concomitant use should be avoided with a P-glycoprotein inhibitor such as clarithromycin, verapamil and amiodarin. So P-glycoprotein inhibitors examples include clarithromycin, verapamil and amiodarin. So this direct oral factor 10A inhibitors are substrates of P-glycoprotein. Okay, so their concomitant use should be avoided with a P-glycoprotein inhibitors such as clarithromycin, verapamil and amiodarin. Then concomitant administration of apixaban and rivaroxaban with the drugs that are strong P-glycoprotein and CYP3A4 inducers. For example, phenytoin, carbamazepine, rifampin, St. John's wort should be avoided due to the potential for reduced efficacy of the factor 10A inhibitors. Then coming to the adverse effects, as we have seen with all other anticoagulants, bleeding is the most serious adverse effect for the factor 10A inhibitors. There is no antidote available to reverse bleeding. Declining kidney function can prolong the effect of these drugs and therefore increase the risk of bleeding. Renal dosage adjustments are recommended for these agents. Abrupt discontinuation of the factor 10A inhibitors should be avoided. So we have completed anticoagulants, which includes both parenteral and oral anticoagulants. Now we will discuss about thrombolytic drugs. Thrombolytic drugs include streptokinase, urokinase, altepase, reteplase, and tenacteplase. So the common characteristics of thrombolytic agents. The mechanism of action. The thrombolytic agents act either directly or indirectly to convert plasminogen to plasmin, which in turn cleaves fibrin, thus lysing the thrombi. So what does thrombolytic drugs do? The name itself, okay, it is understood that thrombolytic means it will lyse the thrombus. Okay, so these thrombolytic agents act either directly or indirectly by converting plasminogen to plasmin. Okay, and this plasmin is responsible for cleaving the fibrin and thereby lysing thrombi. Clot dissolution and reperfusion occur with a higher frequency when therapy is initiated early after clot formation because clots become more resistant to lysis as they age. Unfortunately, increased local thrombi may occur as the clot dissolves, leading to enhanced platelet aggregation and thrombosis. Okay, so this is one disadvantage associated with the thrombolytic drugs. There will be increased formation of local thrombi. Okay, so as the clot dissolves by the action of this thrombolytic drugs, that will lead to increased local thrombi, and this will lead to enhanced platelet aggregation and thrombosis. Strategies to prevent this include administration of antiplatelet drugs such as aspirin or antithrombotics such as heparin. Okay, so here you can see the mechanism of action of this thrombolytic drugs. That is, this thrombolytic drugs will convert plasminogen to plasmin, and this plasmin will cleave this fibrin and thereby lysing the thrombi. And one problem associated with this thrombolytic drugs is that will lead to the formation of increased local thrombi and thereby leading to enhanced platelet aggregation and thrombosis. And this problem can be overcome by administration of antiplatelet drugs such as aspirin or antithrombotics such as heparin. Therapeutic uses of thrombolytic drugs. For the treatment of deep vein thrombosis and serious pulmonary embolism, thrombolytic drugs are currently used less frequently because of the tendency to cause serious bleeding. For myocardial infarction, intracoronary delivery of the drugs is the most reliable route in terms of achieving recanalization. However, cardiac catheterization may not be possible in the 2 to 6 hour therapeutic window, beyond which significant myocardial salvage becomes less likely. Thus, thrombolytic agents are usually administered intravenously. Thrombolytic agents are helpful in restoring catheter and shunt function by lysing clots causing occlusions. They are also used to dissolve clots that result in strokes. Coming to the adverse effects, thrombolytic agents do not distinguish between the fibrin of an unwanted thrombus and the fibrin of a beneficial hemostatic plug. Thus, hemorrhage is a major adverse effect associated with the thrombolytic drugs. For example, a previously unsuspected lesion such as a gastric ulcer may hemorrhage following injection of a thrombolytic agent. Okay, so this hemorrhage is one of the major adverse effect associated with the thrombolytic drugs. And these drugs are contraindicated in pregnancy and in patients with healing wounds, a history of cerebrovascular accident, brain tumor, head trauma, intracranial bleeding, and a metastatic cancer. And we'll see the drugs individually. Altepase, reteplase, and tenacteplase. Altepase, formerly known as tissue plasminogen activator or TPA, is a serine protease originally derived from cultured human melanoma cells, and now it is obtained as a product of recombinant DNA technology. Altiplease has a low affinity for free plasminogen in the plasma, but it rapidly activates plasminogen that is bound to fibrin in a thrombus or a hemostatic plug. Okay, thus Altiplease is said to be fibrin selective at low doses. Altiplease is approved for the treatment of myocardial infarction, massive pulmonary embolism, and acute ischemic stroke. This drug has got a very short half-life in the sense 5 to 30 minutes, and therefore a portion of the total dose is injected intravenously as a bolus and the remaining drug is administered over 1 to 3 hours depending upon the indication. Altiplase may cause angioedema, and there may be an increased risk of this effect when combined with the angiotensin converting enzyme inhibitors. One of the major adverse effect or one of the major side effect associated with this AC inhibitors is angioedema. This altiplase can also cause angioedema. So when these drugs are co-administered together, there will be an increased risk of this angioedema. Okay, so this co-administration should be used with a caution. Next is drug is reteplase. It is a genetically engineered smaller derivative of recombinant tissue plasminogen activator. Next, tenactipase. It is also a recombinant tissue plasminogen activator with a longer half-life and a greater binding affinity for fibrin than altepase. Tenactipase is approved only for use in acute myocardial infarction, and this tenactipase has a longer half-life and therefore may be administered as an intravenous bolus. Next thrombolytic drug is streptokinase. Streptokinase is an extracellular protein purified from culture broths of group C beta hemolytic streptococci. It forms an active 1:1 complex with a plasminogen. This enzymatically active complex converts uncomplexed plasminogen to the active enzyme plasmin. In addition to the hydrolysis of fibrin plaques, the complex also catalyzes the degradation of fibrinogen as well as clotting factors 5 and 7. With the advent of newer agents, streptokinase is not preferred nowadays. Though non-fibrin selectivity and allergic reaction limit its usage, but it is still used for the treatment of acute myocardial infarction, acute pulmonary embolism, deep vein thrombosis, reperfusion of occluded peripheral arteries and venous catheters because of its lower cost. Okay, so here you can see the mechanism of action of this streptokinase. The streptokinase will forms a complex with the plasminogen, which is the streptokinase plasminogen complex, which will convert plasminogen to plasmin. And this plasmin is responsible for the lysis or the degradation of fibrin and thereby the formation of fibrin degradation products. Next one is urokinase. Urokinase is produced naturally in the body by the kidneys. Therapeutic urokinase is isolated from the cultures of human kidney cells and has low antigenicity. Urokinase directly cleaves the arginine-valine bond of plasminogen to yield active plasmin. It is only approved for lysis of pulmonary emboli. Off-label uses of urokinase include treatment of acute myocardial infarction, arterial thromboembolism, coronary artery thrombosis and deep vein thrombosis. Its use has largely been supplanted by other agents with a more favorable benefit to risk ratio. Now we are going to discuss about the drugs used to treat bleeding. So the first and foremost one include the aminocaproic acid and the tranexamic acid. Fibrinolytic states can be controlled by the administration of aminocaproic acid or tranexamic acid. Both of these agents are synthetic, orally active, excreted in the urine and inhibit plasminogen activation. Tranexamic acid is 10 times more potent than aminocaproic acid. A potential side effect is intravascular thrombosis. And the next one is protamin sulphate. As we have already discussed, it is an antidote for bleeding caused by heparin. It antagonizes the anticoagulant effects of heparin. This protein is derived from fish sperm or testes and is high in arginine content, which explains its basicity. The positively charged protamine interacts with the negatively charged heparin, forming a stable complex without anticoagulant activity. The adverse effects of protamin sulphate include hypersensitivity as well as dyspnea, flushing, bradycardia and hypotension when rapidly injected. Next one is vitamin K. Vitamin K1 is also known as phytonadione. This vitamin K1 administration can stop bleeding problems due to warfarin by increasing the supply of active vitamin K1, thereby inhibiting the effect of warfarin. And vitamin K1 is administered via the oral, subcutaneous or intravenous route. Intravenous vitamin K should be administered by slow IV infusion to minimize the risk of hypersensitivity or anaphylactic reactions. For the treatment of bleeding, the subcutaneous route of vitamin K1 is not preferred as it is not as effective as oral or IV administration. The response to vitamin K1 is slow, requiring about 24 hours to reduce the INR. This 24 hours is the time required to synthesize new coagulation factors. Thus, if immediate hemostasis is required, fresh frozen plasma should be infused. And the next one is idarucizumab. It is a monoclonal antibody fragment used to reverse bleeding caused by dabigatran. By binding to dabigatran and its metabolites, idarucizumab neutralizes the anticoagulation. And this drug is administered intravenously and is rapidly eliminated. Idarucizumab is used in emergency situations in the inpatient setting. Because this drug reverses the effect of dabigatran, thrombosis is the most serious adverse effect of idarucizumab. Okay, so we have completed this chapter. So far we have discussed about the anticoagulants, thrombolytic drugs as well as the drugs used to treat bleeding. Thank you everyone. Thank you for watching this video. Let's see in the upcoming session.